Hi, everybody. Thanks for joining. We're just waiting a few minutes. Hello. Hi. Sorry, we might have to mute. We might have to mute everybody in a second because of some. Yeah, thank you. Okay. Thanks for joining. Kiripon, can you hear? You might be
Very
muted.
well.
Yes, hi.
Hi.
Good morning, everyone. Thank you for joining. We can just maybe wait another minute or so. We still got some people coming on. Thanks for all of you who've come back. We're going to do some venous sinuses today. We have a presentation by Dr. Kiripong Srivatanakul from Tokai University in Kanagawa. Kiripong, thank you so much. So we have some of that. Then we have a few more other slides and then some cases. We welcome everybody. Again, this is a free activity, purely educational activity in this time when the education is primarily online. You know, that's the way it is. Might be here to stay for some time. We'll see, but there's a lot of intrinsic value to online education, of course, other than what we're going through. So let's see. If you are not, if you have a question, what you can do is you can, for those of you that are new to Zoom, if you go to this chat window at the bottom, you can chat everyone, or you can either chat myself or Eitan Raz as a moderator, but probably better if you chat everybody and ask a question. And we'll be getting through the questions as we go along. You can also, you know, ask a question with voice, of course. Just be mindful if you're not speaking, please mute your microphone for the background noise. We want to, of course, maximize participation, but if you're not speaking, just mute the background. Having said that, let's see. Why don't we get started? Again, we are super fortunate to have Kiripong presenting today. The topic is venous sinuses. Kiripong, see if you could share your screen. There's a way to pin the screen that we might look into so that as if others speak, you could still see the screen that you have. Yep, we got your screen up.
Okay, I think it's working.
Uh-huh, excellent.
Okay.
All right.
Okay, so, okay, good. For me, it's like good evening and good morning to everyone. BANANAZ again, it's kind of like we're like automatically connected every Tuesday morning for you, night for us. So this time I'm going to talk about dural sinuses. We talked about superficial venous systems last time, and this time I'm going to talk about dural sinuses. And probably Maxim is going to show you some cases at the end to kind of like complement my talk. Okay, so okay, try to advance my. Okay, this is actually a picture I took during a flight actually to China. I haven't been to China for a few months. That's a good thing. And this was very fantastic. I don't know where exactly this thing was, but looking out of the plane window, I could see all these veins draining into this, it was the sea actually. It looks so much like the superior sagittal sinus draining into superficial veins. It's a pity we have the clouds over here. I got a better angle. I didn't get my camera out fast enough to get a better view of it. But anyway, the veins, they're like small rivers. They collect, they gather and gather and becoming larger, and it drains into the larger ocean or the sea, like sinus in the brain. And something different from the rivers. Usually the rivers, they don't connect to one another, but for the veins, you will have connections from this system to the other system most of the time. Okay, so this is the basic plan of the thing. So when you think about the veins, you think the small rivers, the tributaries, and the connections that we don't usually have in the structure of the rivers. So these are the connections. Okay, so you see my mouse. Okay, so this is connecting the superior sagittal sinus. So these are called the labia, the sylvan vein, the trola. They're all like anastomotic veins of labia, anastomotic vein of trola, and so on. So actually, they are named as they connect around here. They can connect the superficial sagittal sinus to the cavernous sinus, or also to the transverse sinus. Okay, so think tributaries and think connections. So we start with superior sagittal sinus. So these sinuses we're covering, we will do the cavernous sinus next in the next session. So it's not going to be something very, a lot of too much information and all this stuff. So it will be things you're most familiar with some variations. Some of you might have never noticed before. I try to go through this. Okay, so we start with the superior sagittal sinus. You know which it is. Okay, so these are this is a very large sinus, the longest one probably we have in the cranium. So where actually does it start? Okay, I drew this one. It extends up to the actually what they call the ferment cecum. It's at the midline of the anterior cranial base, but usually we don't see that in most adult veins. Okay, so in real angiograms, it might start as very rostrally, as in this case. It's a little bit difficult to see. This may be better on the next screen. This one, you see the cristagalli over here. So it receives a vein from the area of the cribriform plate, forming the very beginning of the superior sagittal sinus, and goes back all the way to this the torcula. Okay, so this is probably the full length of the superior sagittal sinus, and we can have something on the other hand, something like this. You can see on both injections from the right side and from the left side, we don't see the superior sagittal sinus rostrally. So sometimes it's absent in the front part. Okay, you have to be able to recognize this. Sometimes there are variations. This is published in AJNR by Diego San Millan. He says that there's one like this, or something that like splitted superior sagittal sinus, like this one, the one I've shown you. The anterior part can be absent, or anything in between. This one has on the right side, but not on the right side, but not on the left side, something like that. So you have to be careful about these variations. They can be absent at the rostral part. Okay. So going back a little bit backwards, I saw Ethan posted a very nice splitted superior sagittal sinus on the, I think it was on Twitter of neuroangio.org. That was a very splitted one. This one that we found recently was something like this. So there are variations of this superior sagittal sinus that you should be aware of. If you try to pass your catheter, it doesn't go where you want it to go. You might have to recall this kind of fenestrations and openings. Okay, so the tributaries, this is quite simple, okay? It will drain the veins as you probably have imagined, nothing that strange, okay? Sometimes you see some venous lakes around the junction between the cortical veins and the superior sagittal sinus. And okay, so this is not probably a lot of things that we need to talk about. This is, so another thing, if we get an occlusion, like this one from a tumor, probably a meningioma, it has to find other pathways to exit from you know, to drain the veins of the frontal area. So this one is just got occluded because of this meningioma. So what did it do? It would probably be easier to just drain through this superficial middle cerebral vein or through the labia, but sometimes they cannot find that route. So what they do, what the venous system did in this case, so this is in the front, this is in the back. So there's some occlusion around this area. So it drains through this. Actually, you can see from this contrast enhanced MR, you can see a channel of the vein inside the skull, the bone itself. So this is a diploid vein draining instead of going posteriorly because of the occlusion. Okay, so this is another case. I think it's a different case. Again, it drains through these diploid vein. It looks like the SMCV, but actually it's not. It's inside the bone itself, actually exiting as an emissary vein over here, which is not very common. Usually it drains through near the lesser wing of the sphenoid sinus and joins into the cavernous sinus. But this one, actually, it drains through this emissary vein, which is quite strange, okay? You can see it better on the 3D, like this one, okay? It's going inside the bone. It's running inside the bone. So this is more simple pattern, just drain, it just is this connection at the surface of the brain through the SMCV, just to join the system of the cavernous sinus. Maybe this one doesn't actually join this cavernous sinus, but goes into the vein of the foramen valley or something similar to that. I take you back to this slide again of the same patient that used the drainage through this diploid vein over here. It looks quite not very familiar to me because you don't see the sigmoid sinus very well here because it's a little bit, the phase is a bit early maybe, but you can see some prominent structure over here, which usually we don't see this large very often. So again, this is at the front, this is at the back. We see some cortical veins, prominent one, draining the frontal lobe into this structure, which is actually the inferior sagittal sinus. And this one will run posteriorly to join the straight sinus and to drain to the torcular. Okay, so sometimes we see, sometimes we don't see. You see it from this another patient. It joins. This one joins more very close to the junction to the vein of the Galen, but it runs at the inferior edge of the falx, collecting the cortical territories along the way. And actually, these the other ones are the deep venous system, and this one is basal vein of Rosenthal. We probably have another session to cover that. Okay. So we go on. Sometimes we have some, you know, other types of connections. Okay, like this one. We have a clot inside the posterior part of the superior sagittal sinus. So the brain needs to drain somewhere else. This one chose to drain through this, what we call the Faustine sinus. Usually it joins this superior sagittal sinus to this straight sinus area over here. So this one, the patient was lucky. She could drain the anterior part of this superior sagittal sinus into this Faustine sinus to go into the straight sinus. So there are variations, but these are something like a pattern that you need to recognize. Sometimes you see it. Okay. Okay, so we move a little bit backwards. Transverse sinus. Okay, I won't be covering every single sinuses because we probably need a lot of time, and doing through this internet, it's a little bit, you know, you feel a little bit of distance between the speaker and the listeners. I cannot see all of your faces. Okay, some of you might be sleeping already. I don't know. So we just go on to the transverse sinus. Some important points that you should recognize. Okay, so this is not very strange to see a large transverse sinus on the right side, while we see it a little bit smaller on the left side. Usually it's more prominent, more dominant on the right side. And so the transverse sinus has a very interesting embryology. So this is a very famous paper. If you have time during your lockdown or anything, you don't have work to do, look through this. Usually Asian and R, you can download without any charge, okay? So this he was describing this ballooning of the transverse sinus in the fetus, okay? So this is the superior sagittal sinus. This is the what is to become the superior sagittal sinus. And the one in the middle, we can see there's still a very prominent development of the what we call occipital sinus. Okay, so this is the marginal sinus. It looks quite different from the adult stage, but we'll see some remnants of these sinuses in adults. It's not very rare to see this. Okay, tributaries again. We have the very famous, the vein of Labbé. Okay, it can connect a little bit more posteriorly or a little bit anteriorly. There can be multiple. You don't know which one you can call Labbé anymore. It's like can be variations of the brain, the veins. And we can also have tributaries from the supratentorial venous system. Actually, this one is not that common. This one is draining the system of the SMCV. Usually this one goes into the cavernous sinus most of the time, but sometimes it just bypasses the cavernous sinus, going posteriorly to become the tentorial sinus and to drain into the straight, into the transverse sinus. A very important point that when you see something like, you know, more round on the way, and at some point it becomes more, you know, flat, this will tell you that it has entered the dura mater and it runs inside the dura. So it becomes a little bit flat in its appearance. So this is a point, very important to recognize any venous structure that runs into a dura. This patient has another peculiar looking vein over here. We'll talk about that later. Probably Max will show some cases on that. It's one of his favorite, I think. Okay, so it drains the Labbé, it drains this SMCV also sometimes. Okay, so this is one of the examples. So this is the supratentorial venous channel that Maxim just named something like this. So this is, you can say that this is one of the tributaries to the transverse sinus as what we call the Labbé, but it's not really a cortical vein anymore. You can see its flat appearance here again, and you can even see a, you know, a little bit lack of contrast over here, which shows there's probably an arachnoid granulation inside there, which usually we see inside dural sinuses. So this is actually the transition part from the cortical vein for it to become a dural sinus. What is actually over here. So if we do a surgery or something, if we try to cut open the dura over here, you will not only cut dura, you will cut also the vein of labia, which can cause very serious problems. Okay, again, flat. You can see on this rotational venography, you can see here. Okay, it's become flat. It's more convincing when you see it moving. Huh? It's a little bit more wide on this view, but when you face it from the front like this, it becomes flat. So anything you see like this, you should suspect the thing to be running inside the dura. Okay. Another tributaries going to transverse sinus, that would be posterior fossa veins. We'll probably have another session to talk about that, so I won't go in detail on this. But just to summarize important points on this, we have the labiae. Sometimes we do like venous sinus packing of the transverse sinus to treat dural AV shunts. But every time we do that, we have to look for this, you know, especially the vein of labiae, the junction to the superior petrosal sinus, and this will be a very important connection to the posterior fossa and also the supratentorial area. We'll probably have that later on in other sessions. And okay, we have also the veins draining the temporal or this occipital lobe area like this. So these are the veins that you have to always, sometimes you don't see it in the injections, but you have to try to look for them, try to recognize that they're there. So there's a rule in general that the supratentorial veins will drain more laterally into the transverse sinus than those in the posterior, from the posterior fossa. So put in drawing, it might be something like this. Okay, I've drawn this to make it the vein of labiae entered in another fashion. It becomes a little bit of like tentorial sinus before it joins actually the transverse sinus. Okay, so this will be more lateral. The veins from the posterior fossa are more located medially. Okay, so this leads you to there are very few classifications on this tentorial dural AVFs. The most famous one is probably done by a surgeon, neurosurgeon, but this is from, you know, endovascular point of view, from Luc Picard from France. So the ones that are more lateral, it will drain, as we have known from anatomy, supratentorially. The ones that are more medial, they will actually drain more into the posterior fossa. Okay, so every time you see a tentorial AVF, usually it fits this kind of anatomy, the rules of anatomy. So we go a little bit more to the confluence of the sinuses. So it's the junction between the superior sagittal sinus, the left and right transverse sinus, and also the straight sinus. So in this case, it is very symmetrical, the left and right and the junction of the straight sinus. But that's not always like that. It's not always like that. In this case, we have a little bit more lateralized. The straight sinus is a little bit more deviated in onto the left side, and actually this is not just a coincidence. Actually, when we have some asymmetry in the drainage of the straight sinus, usually these are a little bit more in detail, but actually, as a rule of thumb, if you have a deviated drainage of the straight sinus, usually the straight sinus tends to drain more into the left transverse sinus, and the superior sagittal sinus will kind of like flow more continuously into the right side of the transverse sinus. So this is some other variants of the sinuses around the torcular area. Sometimes you see something like this. So this is the regular transverse sinus, but on the left side we don't have that. Actually, I think I have another. No, not. So this, even from the left side injection, we didn't have any transverse sinus on this side. So this is a substitute of the left transverse sinus in this patient. The labia was there, the labia was draining into the sigmoid sinus, but the patient didn't have any transverse sinus on this side. I think I have the opposite side injection. So this is the picture to describe the logic behind this occipital sinus. So it's a remnant of this embryologic structure when we were like a fetus. So this is the injection on the left side. We see the labia system draining here, but we don't see any thing on this the transverse sinus on this left side. So this is the substitute for this one. Again, if you are a surgeon, you try to open up the posterior fossa, approaching posteriorly, you might cut into this one and again cause very much damage to the venous system. It might drain from to the opposite side, but anyway, sometimes you should realize this structure before when you go into posterior fossa. Okay, I will finish my talk on this kind of another system. So the sinuses usually they exit through the the jugular foramen to the internal jugular vein and stuff. But sometimes it has it exits through the bone, like emissary veins. There are a lot of them, especially posteriorly. So like this one, usually it's around the torcular area. This one is called occipital emissary vein. Maybe come a little bit lower down. This is a mastoid emissary vein, which is the same place that we see the mastoid branch entering the skull from the occipital artery. And lower down, we see a lot of condylar veins. This one, I think it's probably the posterior condylar veins that we are seeing here. Okay, so these are the emissary veins that we see around this area. Sometimes it is said that when we are on our supine position, as we are on angio table, usually the main venous drainage will be through the internal jugular vein. But this is not a patient in upright position, but I don't know what's wrong with the patient. The veins drain a little bit differently from the normal state. So you can see, okay, I've paused here. You don't see a lot of the internal jugular veins, but you see the patient is using most of these emissary veins to let the drainage from the brain, including from the ones from the cavernous sinus, out of the skull. So this is quite interesting observation. Okay. So again, when we are lying down, usually it drains through the internal jugular vein. When we are upright, they say that this jugular vein will collapse a little bit, so to let the other venous system take in charge of the drainage of the brain. Okay, I'll end my talk with this little bit strange drainage. Strange vein, maybe we found maybe 2 weeks ago. Okay, so we are talking about dural sinuses. The superior sagittal sinus seems to be okay. The transverse sinus seems to be okay. We don't see much here, so maybe that's not something I wanted to tell you. The labia seems to be here. We don't see the top of this vein, so it's probably nothing very interesting. Nothing much here either. But we look here, we see the straight sinus. That's okay too. But here we have something joining the straight sinus. Okay, so we see a vein here. This is actually the basal vein of Rosenthal. So it turns a little bit abruptly over here and going back, but it appears a little bit, you know, it becomes wider and thinner, the ossification. So this structure actually, it's probably quite round in its shape up to here. And from here, it becomes flat again. Okay, so anytime you see a flat thing, that means it's probably inside a dura. Okay, so what it is? So we put this in 3D. You can see it more easier that it's really actually flat. Okay, change the color, make it move, make it more convincing. So it doesn't look like anything that runs into the runs freely in the free space, but it's like confined in this dural sleeves. So it becomes flat like this. So this is actually another type of tentorial sinus. Actually, this is basal vein of Rosenthal. It has kept its the embryonic stage of it, like we call this one embryonic tentorial sinus of this drainage of this basal vein of Rosenthal. Usually it joined the vein of Galen, but this one actually comes posteriorly to join almost very close to the torcula to the straight sinus. Okay, so these are the extra sinuses that we should recognize when we see something flat on your screen. Okay, again onto the okay. I did that 3D rotation. The patient was having a dural AV shunt, a dura shunt around this area, but it was a benign type, so there was nothing relevant to this one anyway, but just to make a good picture of it. Okay, so this is what I wanted to show you today. I have left out something like this superior petrosal sinus. This should be covered along with probably the posterior fossa. The straight sinus I didn't talk about a lot. This should be covered with the deep venous system maybe, and the cavernous sinus. We'll have that in the next 2 weeks. Okay. Okay. Question time.
Kiripong, thank you so much. This is an amazing tour. Please either ask your questions with voice or type them into the Zoom chat.
Yeah, you can chat, you can speak.
All right.
Kitipong, this is Ethan.
Oh, I see a heart there.
Can you hear me?
Yeah.
Okay. Can you just like very briefly like touch on the embryology of the dural sinuses? Really like just a summary of in a couple of sentences.
In a couple of sentences. Wow. That's quite a difficult question. Well, I've shown you some on the posterior part, which is probably the most important thing that we need to know, right? The cavernous sinus, it wasn't originally supposed to drain the brain, but it captures the veins later on. So sometimes we see the tentorial sinus. Probably the ballooning of the this transverse sinus thing describes a lot of variations that we see along the transverse sinus area. I don't know, embryology. It's
yeah. I mean, the reason why I'm asking is because it's really like while the we all talk always about the embryology of the arteries, and we kind of understand the basic concept, right? You have a single trunk that then like ramificates, and then like there's fusion.
Okay.
Like we understand the basic concepts of the arterial embryology, You know, the venous embryology is always a little darker sort of a spot.
Yeah, so I see what you mean from making that question. Yeah, it's you're right. It's not as well studied as people do in arteries, especially when it comes to embryology. Even for, you know, variants, it's still, you know, understudied. I think we still find some, you know, well, the super tentorial venous channels is one of those, probably.
There is a question from the audience about can you clarify the concept about the supine versus upright venous drainage? Is this the norm, or that case was a variant? Can you show it again?
Okay, I don't know what that patient, the problem with the patient, that certain patient. Usually, when we are lying down, we will see the drainage more prominent through the internal jugular vein. When we do angiograms, usually people are lying down, so we see this. But when we are upright, actually, the jugular veins tend to collapse. There has been studies in animals also, but probably not in humans, that they make people stand up and do angiograms. Usually they drain more into the vertebral plexus because they don't collapse. Probably that's what they say. The reason that it drains differently. Okay, I don't know what happened to this certain patient. Actually, there was no occlusion of the internal jugular veins. Sometimes we see, sometimes we don't. She's intubated. She was being evaluated with like subarachnoid hemorrhage. But we didn't see the jugular veins. We see a very good system of the. So these are the emissary veins, the condylar, posterior condylar veins, and some drainage into the. So this is inside the vertebrae. So it is the vertebral plexus, internal vertebral plexus. But she was fine. She had no problems with like venous hypertension.
I mean, it's possible.
The explanation is just, you know.
It's possible really we don't understand a lot of things about the vein because we really don't image the vein in the way that humans most often are positioned, you know.
Yeah, maybe there were some studies using MRs on this topic. I probably have read about some, but I don't really remember what they were.
There is a question from Amitsa who asks what is the protocol for 3D DSA for venous sinus evaluation?
For a venous one, okay. I thought that was coming. I was preparing some slides, but I actually did put it up here today. We did a case of cavernous sinus shunt. So I was wondering, some people might ask. So what we do, we will, like, if you want to get a good view of this, you know, this 2D phase on 3D, I would try to make the start of the run of the rotation maybe 2 seconds after this, the perfect shot, you know, a little bit late. Usually it's 8 to 9 seconds delay in the X-ray time. So you inject as usual, maybe into the internal carotid artery, maybe 3 milliliters per second, and not for so long, maybe 7 or 8 seconds, or else you will get the, you know, the arteries also. It's okay to get arteries at the end just a little bit, but if you want to get a vein, so make like 9-second delay in most of the time and inject about 5 seconds, and most of the time you get a good picture of the 3D.
Okay, good.
I think it's also like just to go back to the condylar and the emissary veins, like just emphasizes the point that there are many ways for the blood to leave the head. If the jugular vein is compromised, you know, most of the time, there will be some other solution, especially if it's a developmental issue. We have a pulsatile tinnitus practice, so we on occasion see a patient that presents with this kind of disposition where the jugular vein seems to be compressed between the lateral mass of C1 and the styloid process, which is kind of like, I guess, the CT appearance. I might have a picture of that, but the more you look, the more you see. The more you see like your typical like neck runoffs, there's usually a stenosis there, right, Kitty Pong? So like maybe positional aspects can be brought into play there too, but there's a physiologic area there where the vein becomes a little bit narrow, more often than not, probably. And then to the extent that it does, there could be a wealth of these other emissary veins or so forth that will do the job. And I think it's important that sometimes they're mistaken in literature and elsewhere as pathologic adaptations, but I think more often than not, they're physiologic. What do you think?
Yeah, I do agree with you. I think that the one I just shown you was not pathological.
Okay, there were a couple of other questions. Some were just wanted to elaborate more on the standing versus laying down business, which I think is something that is under investigated generally, right? Let's see, Ethan, are we missing any questions?
There's a question from Redmi. How do we distinguish an anterior superior sagittal sinus thrombosis from congenital absence? You want to answer, Kitpon?
The rostral part, because we don't see those at the posterior end. Usually it's at the rostral, at the anterior part that you see the abscess.
He's asking the anterior. Like the question is, how do we distinguish anterior superior sagittal sinus thrombosis from congenital absence?
We see the veins, the cortical veins, they will run parallel to what's supposed to be the superior sagittal sinus to join more posteriorly, and you don't see the venous congestion. On angios, that should help you enough, I think. What do you think? Any other better answer?
Yes, I also think it's pretty rare, an isolated anterior superior sagittal sinus thrombosis. I don't know, I've never seen it. I don't know if anybody else did, but an isolated anterior only SSS thrombosis, I'm not sure. Because it's I don't know. I mean, it would be interesting to see a case.
Hey, this is Sankyu.
Hi, thank you.
Hey, so that to me that if it is a congenital, then it should not show any clinical symptoms, or at least if you do the angiogram should not show angiographic venous congestion, right?
Yeah.
If it is actually that the thrombosis, then you will see that the diverting venous drainage patterns of the superior sagittal sinus territory. So perhaps that's the other one thing that we can consider for the angiographic or even MRI. You see the MRI and showing that the significant venous congestive encephalopathy, then you can say it could be at least even it could be partially congenital, that it is the problem of the venous drainage. I have a question to the Kitipong, that you showed the some kind of the deep venous drainage patterns to either straight sinus or the transverse sinus. What is the clinical implication you want to tell? Is that showing that you have some kind of consideration of the pattern of the dural arteriovenous fistula presentation, or it related to that some clinical consequences? If not, why you're emphasizing there is different pattern?
Okay, because Max told me to do so. No, we are actually trying to pick up the cases like this. And but yeah, sometimes we'd have like tentorial. The tentorial ones are more well recognized, but the ones on the convexity is not that well recognized. And but sometimes, yeah, we do see, not often though, because the dural shunts are not very that common, the disease itself. But we see shunts in those areas that are not very explainable if you would say it's just a transverse sinus dural shunt. And for the tentorial embryonic tentorial sinus ones, it's probably more important for the surgeons when they go to cut the tent just to remove the tumor or something. Sometimes they can cause very serious problems if they cut into the drainage of the basal vein or Rosenthal. Just to show the variations.
So the basically variation and awareness, is that your point? Yeah, the thing is, I think that's I mean, it makes good sense. But the main reason that I actually asked this question is that there are so many classifications. And if the classification does not actually address the embryologic or developmental issues or clinical implications such as prognosis or the treatment strategy, I don't know if we need to remember all the classifications for anything.
Yeah. Yeah, I was just referring to the classifications by Luc Picard because it actually fits the you know, the normal anatomy patterns.
Another question to you, Kittipong, is there have been some kind of discussions. You just sharing this picture nicely is exactly matching to my question. That this kind of the preference drainage, this is going to the right side. Left side is a little hypoplastic. Is there any explanation why somebody has the right, somebody has left? Do you have any explanation for the anatomical perspective? There are some discussions about some asymmetry of the torcular itself is the potential explanation for this drainage pattern. But since you prepared this talk, wonder if you actually have seen any kind of the publications, other things, why somebody has the right to left. Is that right-handed, left-handed? No, that was joke. But there was some kind of suggestion, or in embryological standpoint, there was a cardinal vein development on the left side, and that's one of the.
I don't know. There are explanations that the cardinal vein on it makes the superior sagittal sinus drains more easier on the into the right side and stuff, but it's not very clear why it is so. But the difference, the laterality for the, you know, the left and right, I don't have the exact numbers. I've read a few papers on those, but I think there are the percentage from study to another study is very different. I was going to go through my own cases, but I didn't have time to do that. But in my own experience, sometimes we do have like transverse sinus, superior sagittal sinus thrombosis all the way to transverse sinus, but sparing the you know, the straight sinus, which drains into the left side. So we don't have any clot in the deep venous system, so the patient is quite fine. Well, we do see those cases, but I don't know what is the real explanation. People say that the SSS, the superior sagittal sinus, just drains more easier into the right side because it's there's a larger vein on that side. I don't know. Do you have any explanations for that?
No, not me, but the other.
Yeah. Every time we do that, we get interesting questions. And like the last time someone asked, how do you differentiate between a sinus thrombosis and a dural shunt when, when we have the venous congestion in the system? After we closed the session, I was thinking, if we have an acute thrombosis of the venous sinus or superficial veins, usually we don't have dilated veins around to compensate with the disturbance of the venous system.
Well,
Okay,
I think that you can do the MRI. You can easily find this from
okay, also on the MRI, yes. And if we have a cortical venous reflux from the dural shunts, we will have dilated veins because it's, it's not acute, it's a little more chronic. So the drainage system kind of like have time to adapt to the reflux, and they are more dilated than in those cases with acute thrombosis of the sinuses or even to the cortical veins. That's what I thought about after we closed the session the last time. So every time we have a session, we have some interesting questions that sometimes we cannot answer instantly,
I think that I saw one of the other contributor typed that thing. So in conjunction, in conjunction with the because that skull maturation, in conjunction with the idea, I think that it's absolutely true. We don't know that the skull and skull base has been developing and mature exactly what time. Well, my experience the long time ago was I had a PLAV fistula patient. We were treating in a very staged fashion, and then the patient lived a couple of years. The problem happened was the continuation of the high flow fistula to one side was creating the right heart volume overload, and it eventually developed the jugular bulb, the bony stenosis. So I think it is the one of the consequences of protecting the heart. And in that regard, the skull base and skull is also that connected to the development of the dural sinus, and perhaps is also related to the flow through the dural venous sinuses. That's what I think.
There were a couple of comments from Dodi and Kim Nelson about the right-sided dominance. I don't know if they can speak more about it, if there's a microphone. Dodi?
Hello?
Just, yeah.
This is Dodi. Can you hear me?
Yes.
It was just a guess, of course, but for me, the point is that it is not the channel that determines the flow, but it is the flow that determines the channel. So you have channels there where you have flow, and it's not that you are born with channels and then the flow goes into it, but you are born with flow and then the channels come out, and they may be arterial or venous, it doesn't matter. So whatever we see is really just a following how the flow goes and comes back. That's my thought. I don't know if I was clear enough, but
No, I think it's very like the physiology of this, the way how this works in real life, all these postural changes, all of this, I think we're just scratching the surface of all of that.
I agree with you, Dodi, that the flow should initiate this whole thing. However, actually, if you see that the embryology of the dural sinus development, it is like the plexiform from the continuation of the PL vein to the meningeal veins, and then eventually those plexiform thingy is going to be like that as Okudera described, make the ballooning of this one of the plexiform channel and communicating with the adjacent channel. That's my understanding. So in that regards, if the flow is good enough, make a ballooning, and then make the single or bigger channel. But if that's something happen, like a thicker guy actually adjacent to that, then it probably try to find a different channel. So I agree that the flow will initiate and perhaps it should initiate, but the anatomical development of local circumstances perhaps contribute to some of these variations and the development of dural sinus.
Max, hold on. There was another question that I think it's very interesting. Can you hear me?
Yep.
Kitty Pong. The question is essentially like, what's the role of the jugular bulb? Like any idea? I mean, Sion also like was interjecting with his knowledge, and Dodi like, I mean, jugular bulb seems to be something there with really no role. The question is really like about the maturation. Why does that happen? But any comment about this?
Yes, Sri, thank you for that question. Thank you.
What do you mean? The maturation of the jugular bulb?
Yeah, the question is from Sri. What is the importance of jugular bulb maturation? Why does that happen? And I would add to that, what can be a potential role for the jugular bulb? You know, like something almost look like an isolated pouch there, like really like very, very enigmatic to me.
I don't know. Never thought about that.
Okay.
We see in the vein of Gallens, the maturation is not catching up, and we have the problem of the drainage of the vein. But in normal situation, why does it develop? I don't know.
Okay.
Anyone? I mean, we know that the venous system matures even after birth, right? We all, that there's plenty of examples of that. And beyond just hemodynamics, I guess what Dodi is referring to in terms of like relationship of the bulb to the flow patterns.
Well, I think that the jugular bulb is extremely important. Because it is the channel, the eventual channel, connecting that the brain's venous drainage to the right side heart, right? And you want to actually converge the multiple venous channels that to one large without valve type of the pathway to the right heart. If you see that the venous embryology, there are multiple the venous channels developing through the PL network and going, some of them going through the deep venous sinus, especially cavernous sinus, as Kitty Pong said. Another is going to the superficial sinus, but it eventually comes down to the neck because it needs to go to that the heart, right? It is not just the transverse sinus and the cavernous sinus. There are primitive the head sinus. There are some kind of dorsal pharyngeal vein, and that all kind of the multiple tributaries needs to converge into one side. That is, to me, is the jugular bulb, and the skull base, the bone development is also accommodating that particular area. So I think this is very important that the communicating channel, which deliver that the neural, the tissues, venous drainage to the right heart.
Okay, but I guess maybe the question is differentiating jugular bulb from jugular foramen. Like, yes, we have, I'm not sure, I guess specifically about the bulb, and maybe this is a little bit too much minutia, but yes, we have a jugular foramen because we have a jugular vein going there. But
yeah, that's the point, because the development of that the skull base, all that the skull itself should accommodate the arterial inflow and venous drainage. As we know, if that there is a congenital internal carotid artery agenesis, one of the static imaging the evidence is you don't see the carotid canal, right? So that the point is it is not the skull who make that the channel for that the arterial or venous arrangement, but perhaps the skull and skull base bony development is developed to accommodate that the arterial and venous structure and their function. That's what I think.
No, sure. I
Sense?
think everyone agrees with that. Like that's Dodi's point, that the foramen doesn't exist without its content. That's one of its, right? That's from Lajanius also, but everyone is kind of in agreement with that. But in terms of specifically the bulb versus the foramen, I think it's always good to be comfortable with having more questions than answers.
No, Max, that you have to make it very clear, because if you're talking about the bulb, you're talking about that the venous structure. You're talking about the foramen. You're talking about the bony structure, right? You're talking two different things.
I mean, I think yes, sure. Certainly, we have a foramen through which a vein goes, but the shape, I guess maybe Sri, if you want to maybe table it for later or continue the discussion, like you're talking about the shape of the bulb, the architecture with the relationship to the adjacent structures, to the ear structures, like that's more like to me what seems like to be the real enigma here. So I don't know. Okay, we're going to continue. It's 9 o'clock, but we're going to continue until we have time, until 10. I have a couple of slides, but maybe in the interest of time, why don't we do this? Eitan, any other questions? Dodi had a case. Dodi, can you hear me? Why don't we go ahead?
Yes.
Let's go with some cases now. Can you share your screen?
Okay, so it's already me. Oh, thank you very much.
Or if you need some time, we can.
No, it's okay.
We got it.
I think I'm all right.
Okay, so you can share your screen. I can give you that.
Can you see it?
Yes.
Okay, we were talking about sinuses, so I just thought of showing a case where we had some surprises with the sinuses. It's of course a dura levi fistula, 50-year-old lady with an unbearable bruit, and she comes with this usual dura levi fistula type 1, very high flow, and it drains orthogrally towards the jugular vein, so there is no reflux, and you can see that in this right bottom image, this is the very late phase of the drainage of the brain, and you can see that we have the superior sagittal sinus and the transverse sinus, which are draining in the same sinus where there is the fistula. That, of course, is an important point. If you want to treat the fistula, you should not occlude the sinus.
Dodi.
Yes.
Can I interrupt you for just 1 second? It's too good. I'm sorry. Because you made that point. You made this very point earlier. If you look at can you see my mouse? I don't know if anyone can see that. Let me see if I can do this. If you look at the lower left image, right?
Yep.
Okay. You see all of those channels that are forming the lateral. Like ultimately, they're gonna come together at the lateral tentorial arcade, right?
Yep.
But you see how there's like, I don't know how many there are, a dozen more. There's probably 100 others that are below the resolution. That really goes to your point, like where there is need, where there is hemodynamics, there's going to be flow. We're all taught like, okay, there's a lateral tentorial arcade, there's the Bernasconi Casinari going medially, fine. But underlying all this, there's a network. And that's like just beautifully illustrates like all of these, like what names does each one of these vessels have? Okay. I don't know if there's a name to all of them, but we know where they go. And we know that the idea behind them. And that's just a lateral tentorial network. I don't know if that's a way of seeing it, and I'm sorry to interrupt, but it's just too good.
I completely agree. There is no need to give names. You just say there are lots of arteries everywhere, and they become larger or thinner depending on the need of the flow. So yes, those arteries are there always, and the point is that you don't see them, of course, angiographically, but you can see them if you go there surgically. You would see very thin little arteries everywhere, and they just become larger when needed. Okay, so I just wanted to make the point that you cannot, or you should not, occlude that sinus because it's used by the brain. And here are some more images showing the supplies to this fistula everywhere, and you can see there are vessels everywhere, as usual in those fistulas. So the point here was to treat it. And how? Of course, we don't want to occlude the sinus, so the only way we know is to use a balloon inside the sinus to protect it. And that's what we did. It was, as you see, in 2015, so it's kind of 5 years ago. And we did not yet have the bigger balloons. So this is the largest balloon we had, which was an 8mm balloon. And as you can see, it doesn't really fit to the enlarged sinus. So the sinus is a little bit larger than the balloon. But again, we decided we could go on anyway. And you can see the balloon, which is inside the sinus, but it doesn't occlude really, and the fistula is still open. And we started to inject fill. You can see the fill up here. We started to inject that. You already see kind of an initial phase where some of the fistula is gone, but is still present. So we go on, and here we are a little bit later on. You can see the fill going around the sinus and inside the sinus. So at the end, the fistula was gone. We had a good result. And you can really see that we created a kind of a channel with the fill inside the sinus. So there are all the arteries around filled with the fill. And also inside the sinus, there is kind of a wall, both here and here, which you can say, well, the sinus is gone. Not really. The sinus is well patent, and it's still open, as you can see here. And the fistula is cured. So we were really happy with this result. And the labate vein also was still going and functioning at the end of the treatment. Okay, an MR 6 months follow-up. She's well for 2 years. And then she felt a reappearance of the breed. And now we have, again, another fistula, which is, I mean, in the same region, but posterior to that. And now the fistula is a bad one. It's a type 2 fistula, if you want. So it's in the sinus, and from the sinus, it's going into all those veins everywhere. You can see from the injection of the occipital artery here. So it's a very bad fistula now because all the cerebral veins are interested, and that has to be treated as more importantly than before. So we transformed a type 1 fistula in a type 2 or 3 fistula, as you can see here, with all the labate vein now, and the occipital veins are draining retrogradely. So it's much worse than before. And now the sinus is occluded also. There's the sinus you see here is the one on the other side. You can see, okay, here. So this sinus is occluded on the right, and you only have the one on the left. So the sinus is occluded, and we have a fistula on the other side. So of course we treated her with a new embolization, same thing. We went here and we injected again fill in this region. And now we went here, I'm sorry, and now we have the fill in the vein, which was our main, let's say, the foot of the fistula, which we wanted to be sure it would go away because it's the origin of all the other cortical veins in that region. And so now again, we have the fill inside the foot of the vein. We are happy. The fistula is cured. And we have a 1-year follow-up. What do we have now? Well, we have that the fistula is cured. the vein of Labbé is now visible in the correct direction, and the sinus is open again, as you can see here. So we have had a sinus fistula, which developed to a type 2 or 3 fistula, and then again, it went back to normal with a normalization of the sinus in this region. As you can see here, we have again the sinus inside the field, which was back to normal. Here is all the mess that we did on this region, but finally the fistula was gone and the sinus is still open. So that was, and the vein of Labbé, no, yes, which was going in the other direction before, it's now flowing in the correct direction at the end of this whole adventure. So I just wanted to show this case because I wanted to show how, you know, things can really develop in a way that sometimes they're a little bit surprising. But if you have any questions, I'm here.
Very cool. Okay, please, any questions?
I have a question, though. This is Sun Q from Bronx, New York. So you think that the dural fistula at the site of the vein of Labbé insertion was there before, or it is a new one? What do you think?
I think it's certainly new. I mean, it was not there before, and we did have the whole imaging before, and there was just a simple, very high flow, but simple type 1 fistula of the transverse sigmoid sinus at the beginning. So something happened afterwards. There was a kind of a secondary change, which went in the direction of having a worse situation, as you can see from this last image. So no, it was not there before.
Yeah, so this is an excellent case that I actually very congratulate you about this good result. But I think that the scan, because we know that for some of the dural, especially transverse sigmoid sinus dural fistula, there are some reports, and then I do have my personal experience too. There are actually different channel. It could be some interdural channel of the drainage. So for you that they recanalize the new the dural sinus, what you say, is that the real sinus, or you think is that the recanalization partially of the occluded sinus, or it could be some kind of the interdural venous channel which eventually communicate with the distal part of sigmoid sinus? What do you think?
Oh, that's a very interesting thought. The first question should be, what is the real channel in a sinus? Because there are many channels probably, and everyone could be the real one. Certainly it is the channel where we had put the balloon at the beginning. So that was the simplest channel to catheterize with the balloon at the beginning, which was, it was the big one, the one where the flow was going. I think what we have now is still the same channel, which has been thrombosed during the development of the second fistula, but then again, it became reopened once there is no more the high flow and the pressure of the second fistula to the venous system. So the venous system is really very agile and can move and develop, different opportunities, like any part of our body, really. So
I think that if I may, can I suggest one thing, Dodi? That I think that what about post-contrast temporal bone CT extended to all the way down to the jugular valve, as the other Max said, then we can probably see the your prior that the other embolic material and the other sum of occluded sinus and the location of the enhancing venous sinus area. So if you can get the other the CT scan high resolution, we can probably see much better anatomical understanding where the channel developed.
Yes and no, really, but yes, you can have more information. Not easy to see exactly with all the feel and all that material around there. And all the arteries also, which are occluded by the field, so there is field everywhere. I don't know if you can really understand the anatomy, but it's a good point, certainly.
Sorry, it's a beautiful case, and always cases like these are the interesting ones because they raise so many questions. Actually, and it's a perfect segue into what we also wanted to show today, which is kind of getting into the angioarchitecture of the sinus and the arterial components of dural sinus. And of course, that leads into fistulas, but it's always an interesting question of like, what would be the treatment strategy, right? Like on the one hand, we could say that your initial treatment, your initial vein sparing or sinus sparing strategy is what we ideally would love to pursue, right? You want to close the fistula and keep the sinus, so you have the cake and eat it too. And ultimately it succeeds, right? Like through this interesting development that happens later. Fortunately, right? So that's, and then ultimately you do get to that part, right? You have the labia, you have the sinus, and the patient is fine. Fortunately, the patient doesn't present with a hemorrhage when she develops this more like of a type 2. Second, like when you have a follow-up presentation. Had this patient bled, then the people that argue for sacrifice of the sinus would have a much stronger point to argue that the initial treatment should have been complete sinus sacrifice. Just pack it with coil, like let's not get fancy, just do it and let's have it done with. And that's not how we think of it either. We try to do what you do. We don't have the balloon, but we try in ways we can to accomplish the same thing without the Copernic, which is more difficult. But I mean, what do you think? Like most of the time, obviously the hemorrhages are, I think we get away with it, or not get away, but we succeed.
It's better not to have a hemorrhages if possible. But what I've seen is many cases where the sinus was occluded and with complications afterwards. So occluding a sinus is not really so safe, especially if it's used by the brain. And we could show that it was used by the brain. In anything we do in our job, you have to, decide if you want to have one certain complication or a different one. And probably the rate of complication after a treatment like we did here, which we did probably in 30 or 35 cases, and we had 2 major complications. This one was a minor complications, if you want. It was just an anatomical one. But then we had 2 major complications by doing a balloon assisted embolization of a dural fistula. They are all very high flow fistulas also. So I don't know. I would prefer to not have a complication because I occluded on purpose the sinus.
Yeah, no, I think we definitely agree with you on that. And I think that goes to Kitty Pong's earlier point that occluding the sinus has to involve like a very solid understanding of what that sinus is doing. You know, what is draining into the sinus? Is something still draining into it? Like what is the functional state of that sinus in regard to the fistula and the brain? And I think we can obviously follow up on that, like the techniques of how to understand fistulas, the venous phase of the brain. What an excellent case. Thank you. Any other comments? Boris Pabon says, well, what about using 2 balloons? Like I know of Renee sometimes like tries to kind of like fold a balloon on itself or whatever, like stick 2 of them in there. Exactly. I don't know. I don't have experience with it.
we've done that a few times when it was really big, but in this case we thought it could work like it was. But of course, yes, next time we would like to have a larger balloon, or and we do have it now, because we have also a 10 millimeter balloon now. Yeah. So
but and you I mean, if the purpose is to coat, you know, somehow to coat the wall of the sinus, the inner wall with the fill, that works as well as any other, and you had the sinus open at the end.
Yeah, yeah. I don't know how much strange material you may have in a sinus. Maybe the sinus is not happy to have something which doesn't belong in there, and maybe that's why it occluded at the end, because there was so much fill inside it. Even if the channel was open, but then you had a lot of possible aggregation of things in there, and it finally occluded. Yeah.
And that goes, I'm sure the follow-up of that is like, what kind of antiplatelet and this and that, and okay.
Dodi, quick question. You said that the 8 millimeter is not the bigger one. What other sizes do you have now available?
10 millimeter. It's always the same balloon. It's the Bolt Copernic René Chapeau balloon. I'm not sure. Certainly we have the 8 millimeter and the 10 millimeter. I don't know if there is anything else. The 10 millimeter, sometimes the sinuses are pretty large, but we started this with a peripheric balloon, with the periphery balloons, the ones you use in the peripheral arteries for angioplasty.
The non-compliant ones, the really stiff ones, right?
It's not. I would not recommend it if you have the one compliant. Yeah. But if you really are in the necessity of using something, you could start with a non-compliant angioplasty balloon, peripheral. And of course, you need to have good support, because those are rigid balloons.
Okay. All right. Dodi, thank you again.
Thank you.
Let me jump in on the back of that. We'll follow up with a little bit of with just a couple of slides in terms of some other anatomy of the sinus, and then maybe Eitan, you could show the illustrative cases of that. So excellent. Let me see if I can share this screen with you. There we go. Everybody can hear, right? Okay, so most of this has been more than well covered. We've all talked to, Kitty Fong's point about the rivers. I just want to give a shout out to Netter. Like I love Netter. And as much as we certainly have so many ways of illustrating things, I still go back to that. Like if you go to some of his pictures, there's just the guy had it right. Like there's so many ways in which he was able to see things the way that, we see them, and he's a genius. So if you look at one of these pictures, there's so much information there. You can see so many things that Kitty Fong had talked about. All of these, emissary veins, diploic veins, all of these things. All of that stuff, epidural venous components, it's all in there. But it also goes to the point of when we think about venous channels, why do channels form in certain areas? There's this whole thing about you have two layers of the dura, and of course you have you have reflection of the layer, and so the flow probably preferentially for hemodynamic reasons would form here. But there's no reason why any part of the dura cannot be a channel. And that's all of this talk about dural venous channels that Kitty Fong illustrated. And even though he credits me with pushing it, I think he was actually one of the first ones to recognize it. The first picture of that channel comes from Yunpeng Wang, as Kitty Fong pointed out. And then he had done a lot of work on that. But all, the tentorial sinuses, all of this stuff is just basically channels where there is flow, like what Dodi is saying. It's a way, so that's a functional way of looking at this. So anyway, I'll skip all of this stuff. We don't need to see any of this. But yeah, it's see more of the same, these weird sinuses. You don't need to see this. This goes to the earlier point that was raised. What about a thrombosed, distal or anterior part of the superior sagittal sinus? And yes, we don't see that. But what you see more often than not, like rarely, but more importantly, is to recognize when that sinus is functional, right? So sometimes you have this big, fat anterior frontal vein going into it. You could see it on MR. And that's the angiogram of that same patient. I think we covered that last week or 2 weeks ago. When you have this, right, that's a surgical point. Like you don't want to sacrifice this part of the sinus, though you normally might be, might get away with that most of the time. When there's a disposition like this, you cannot do it. If you take the sinus, there's going to be a venous infarct in the frontal lobe. So that's something to pay attention to. Very, very important. This, that, and the other. Okay, these dural channels that we talk about, you could see them very well in MRI. I think Kitty Pong showed that. So you have this flattened segment. So this is a cortical vein. Can you see my mouse? No?
Yeah.
Yeah, so this is a cortical vein. Here's a transition point. Goes into the dural, like this kind of dural sinus. It's the same as so the tentorial sinus is is common. It's very common, well known. This stuff is less well appreciated, but it's very common too. And so here's the MR, here's the cortical part, and you have this like flattened, it's just a channel in the dura, that's all. And the bigger the vein, so here's a DVA, DVA, same thing, goes into this channel. The bigger the channel, the bigger the vein, the more likely it's gonna have this kind of dural sinus segment, flow-related reasons. So here you see like a very nice flattened segment when you see it on edge. This and that, okay, so we'll skip all of this stuff. Emissary veins, diploic veins, again, Kitty Pong's point, like it's a system. It's just another way to blood to leave the head. You have the jugular outflow, you have the cavernous system, and then you have this it's like the third heart, right? Like a limb. Like you have this third system. And that system, as you showed with your sagittal sinus occlusion, like that system can pick up a lot of slack if it has to. For the, just a general point, when the image, the venous phase, if you want to see these things, the flow in these epidural, in the emissary veins, diploic veins, the flow is a little bit delayed, right? There's more time, there's a resistance is a little higher in that system. It takes a little bit more time for the stuff to get there. So you have to keep the pedal on the metal past what you would think is like, in the lower left image is what would be like the typical venous phase. And look, if it's a late venous phase, you see all of that. And again, it's just a balance. You don't have a big superior sagittal sinus. Why? Maybe it was thrombosed at some point, but probably just how this person was born. And so guess what happens? You have this other system that compensates for that. You can see that in the skull, like all of these. On the skull x-ray, you can, you can see that. So, oh, this is like, whatever, we'll probably skip this case, or maybe not. Okay, fine, let's not skip this case very quickly. There's a patient that presents with this, it's an interesting, it raises a lot of questions, I think. It's a case that presents with this kind of like venous malformation looking thing here on the left. You see the arrows. Here's the MRI. We get a lot of pictures of that. So that's that right there. And there's like positional swelling there and the whole kind of venous malformation clinical picture. Here's a CT. Now you start to see something a little bit funny here. This is the angiogram. So frontal view, you see this like venous phase. And then in the late venous phase, you see that a pacification of the structure, right? Here's the lateral view. Same thing, right? A hypoplastic superior sagittal sinus and drainage of the brain. So the brain venous system in part is utilizing this channel and is in a pacifying this structure that essentially presented as a question for a venous embolization, like a sclerotherapy referral. And I'm not sure, like if we zap this, like would this person not have other ways to drain? Probably she'll tolerate it. Like if we closed it without looking, in this case, we would just get lucky. But once you know this, you know that there's not a really very good reason to try to sclerose this pouch. So we didn't do it. Anyway, how much time? Okay. Okay, not bad, half an hour. So the arteries and the walls of the sinuses. We'll table that. We're going to have a whole year of this going for everybody. So thank you again for joining. There's going to be like, we're going to try to do bi-weekly sessions covering everything. We started with veins because I think they don't get the recognition they deserve. But there's going to be plenty of time for the arteries. So here's like just a schematic. And you see there's like, the more you look, the more you see. There's all kinds of arteries in the walls of the sinuses. Arteries everywhere, right, Dodi? So here's one. So there's your anterior falcine or anterior meningeal artery. You can see how it splits over here. Like you see how the distance widens between them as the sinus gets a little bit bigger. So there's one for each side of the wall. You see them well with fistula. So here's a torcular kind of fistula, right? And so you see like frontal lateral view, posterior meningeal system dumping into here, right? So here's the arteries and the walls. The more you look, the more you see. So more of this, right? So whatever, like a typical kind of torcular, ugly looking thing. And you see these channels coming in. More and more. So this little guy, right? That's in the, probably related to the inferior sagittal sinus. Rare, but see that once in a blue moon. Here's another sigmoid fistula. We'll get into this one particularly. It's an interesting one. But here, so like again, this like Davidov-Schechter, there's all these whatever connections. So you see that there's a dural. So this transverse sinus, sigmoid sinus, right? Like picking up these channels here. So important to recognize these. Again, more. Another fistula here. Another kind of an interesting fistula to see. So here's a channel. That's from the occipital artery. That's a variation from, ascending pharyngeal. So this would be like a variant, kind of like a partial pharyngo-occipital variation, but supplying the, the sigmoid area. The way you can see them very nicely, I don't know if you guys see that, but like one of the ways that we love to show these is to have this double contrast angiogram. You just make the arterial phase your mask, and then you look at the venous phase, and you can overlay the venous phase and the arterial phase. You get some, of course, it's a common carotid injection. And so in these injections, you can get some like really cool looking pictures to show that. Okay, thank you. So having said that, so we've kind of gone into this channel situation. I want to turn it over to Eitan. You show like, I don't know if you could see some of these cases. You have control. Let me get you. Let me get you that. So, all right. I'm sure I've missed a couple of questions since I was yapping here, but maybe someone's picking them up. Let's see what's in the chat. Okay, thank you, Eitan.
Okay. Any question for Max before I show this case? All right. So, Boris Pabon is saying hi. Hey, Boris. So this is a man in his 50s. The information here are anonymized, so even the age is not right. He was around 55 at that time, presenting with bruit on the left side. Interestingly, he has a history of subdural hematoma on the left side that was treated quite a few years before. So when we look at the MRA, I want to just, for the MRA without contrast, to me is the best MRI sequence to look for, to understand, look and understand dural arteriovenous fistulas. So when we scroll through these, we certainly recognize here, like in this region, like abnormal flow-related enhancement in the left sigmoid sinus. But we really can understand much more on this MRA. If we really scroll through, we really recognize like abnormal enlarged arteries that are gonna be the ones supplying the fistula. And we see here the middle meningeal arteries, how on the left is much bigger than the right. And then we see here middle meningeal artery continuing inside. And then when we go lower, we see also how the occipital artery on the left is much bigger than the other side. And so the point is really like that you can understand a lot of the a lot of the the angular architecture of the fistulas on the MRA. Much better on the cross-sectional source images rather than on the 3D. After this MRA, we did an angiogram, and here on the angiogram you see, like, obviously, like, we know it's already a fistula. We're trying to understand it a little better, and we see on this common carotid artery injection, we see an enlarged occipital artery supplying the fistula. Here we see a lot of channels. Again, like, it's hard to give a name to all of these. And then to understand better this fistula, really, like, we have to continue the catheterization, and certainly we look at the ICA to understand the venous drainage of the normal brain. And we see here there are 2 venous sinuses. So the left sigmoid, the brain drains through the left transverse and sigmoid sinuses. So that's an information important. The brain uses that sinus. So we know that we have to keep it in mind for purpose of the treatment. And then when we go to the external, I find it useful, really, like, to go into the distal external. So to see, like, selectively in this case, the supply from the middle meningeal artery. And you see here the arcade from the back going to the back here, and here finding its way through the sinus in this location. This is a more panoramic view, same thing, but we start to recognize that this is the whole sinus, right? And but the fistula seems really like to go in this particular segment of the sinus. Now, to continue the angiogram, in this case, we went to the occipital artery, and again, though, like, we see how the really, like, the drainage is within the posterior aspect of the sinus. So here on this image, we see that a little better. Everything converges to this particular area here. Now, I don't think there was supply from the ascending pharyngeal artery, and neither from the vertebral artery. So patient come back for treatment, and I'll put this on the side, and we went both transarterial and transvenous, and here, so this is a transarterial injection, and we recognize that all that meningeal network draining to the sinus through this particular channel. So what we did next, we went transvenous, and we tried to catheterize from the venous side this particular channel here. And we accomplished that in this particular case using just the simple diagnostic catheter. And as you see here now, like, again, on the left, we have transarterial injection showing this channel. On this screen, what we see is that the transvenous catheterization with the catheter within this channel. Okay, so we managed to catheterize from the venous side what we call it a common, like, arterial collector. We can call this like a vein. This goes beyond this part of the presentation, but the concept is that if we close this particular part, are we able to cure the fistula? That's the question. This after we catheterized, we did this particular injection, which is one of my favorite ever. And essentially, what we see here is, like, it's amazing, because by injecting from the venous side and injecting a little hard, what we overcome the pressure of all the meningeal feeder to the fistula. So we see from the reverse, we see all the supply to the fistula, and we see some sort of like sun pattern here with branches coming from the middle meningeal artery, branches coming from the occipital artery, and so forth. Now, this image shows also that if we embolize through here and we close this, we're probably gonna cure the fistula. So let's see what we did. We went through with a Scepter C to protect from reflux to the sinus, and we inject onyx, and here it is. So essentially, let me see here. Yeah, so this is the onyx injection from the Scepter C, and you see how the onyx really permeates all the arterial network that is supplying the fistula, but it doesn't without reflux into the sinus. So with preservation of the sinus, which was one of the purpose of the treatment. This is the final angiogram that shows that just by doing this, what we call it a super selective transvenous embolization, we actually, like, with a minimal amount of onyx, we cure the fistula. There's no fistula anymore. We preserve the sinus, as will be shown in this image here. The sinus is completely preserved, and with a very safe treatment. Again, like some of the fistula, not all, but we notice that quite some fistulas have something like this appearance, this sort of venous drainage into the sinus. It's not something we discovered. It was already described quite many years ago. But the point is that the more attention you pay to this kind of, particularly this kind of fistula, these sigmoid fistulas, you're gonna find this channel that is usually very, very commonly here to the back of the sinus. And very often, like, selective transvenous catheterization can be accomplished with that would lead then to a super selective treatment of these with preserving the sinus. Any comment or questions?
This is excellent. The other case, Ethan. Congratulations.
Thank you. I mean, I did this with everybody where we did it together. So
I have one question though. That it makes perfect sense going through the vein, especially you actually cannulate it directly for that the venous channel. But the one thing is, as we all know, there is a petrosal branch of the middle meningeal artery that potentially supply facial nerve arcade. How can you make sure the vein is your injection of
okay, so this image shows you that, okay, the Peters branch of the middle meningeal artery comes from here, right? And the facial arcade is here. So as you see, certainly it's something that you have to keep in mind. Like whenever you embolize in this region, you have to keep in mind. But here, as you see, we were pretty like, we had quite some margin from injecting all the way.
I understand, but as soon as you start injecting, you cannot control where it goes. Is that correct, right?
Well, this was onyx, so so you know, like it's something you have to bear in mind for sure. I appreciate the comment. Absolutely. I mean, that's a safety point that needs to be paid attention to. But as you see here, like if the glue would have start going toward this direction, I mean, that's a no-go.
So that actually relate to my next question is, have you considered actually the protecting that the important arterial structure, or also actually the venous reflux toward the major channel of the sigmoid sinus, right? So have you considered that the embolize that one with the coil and protect it?
Yeah, no, and so coiling is certainly an option. I mean, you understand. You're saying coiling here to protect. That's certainly something that can be done. In this particular case, we felt that there was no need. Also, because as much as here we permeated with onyx, I mean, this is a much less amount of onyx than the usual transarterial onyx embolization, right? I mean, this is a minimal amount of onyx. When you see transarterial embolization with onyx, usually you see like a lot of stuff going on, right? So in a way, this is really minimalistic, right? But also, like, in a way, we could have even done less, because I think just permeate a little onyx here could have been enough in this case. So as much as we can, like, we could have protected them. I don't think in this particular case there was a need. But yes, certainly, like, I think it's very important to underline the importance of the anatomical dangerous location, and one of which is certainly the facial arcade.
Yeah, that my suggestion was just the communication part of that the venous channel, drop the one coil and protect the onyx reflux.
Yes. Yes.
So that was
so
this is a wonderful case.
Yeah, that's a very good. Max actually has a case in which same thing. Like, we went through these channels and instead of injecting onyx, like, he coiled it off, and you know, he obtained a cure as well. That's just variant of the theme. Variants of the theme, and but the important, I mean, the message from here is really like, I mean, there's other ways to. There may be there may be, if you look very carefully to the angioarchitecture of the fistula, there may be alternative ways than the usual transarterial embolization or the usual venous sacrifice, and this is one of them.
Let me show another
Great
case.
case.
Let me show the same case. We'll address some of the points that you've raised, because I think it's you know, it's basically a very similar case, but it sort of illustrates, and because it's similar, you kind of I want people to kind of see the pattern. Like most of the time, where we've encountered these channels would be in like a lower grade fistula. I think when the sinus gets messed up and destroyed by the fistula, it's hard to tell what's what anymore.
Let me stop sharing so you can show yours.
Yeah, but you know, and these would be like type 1s or low grade ones. And as you mentioned, Shankyu, like this is where you don't want to run into trouble because they're low grade. Usually it's just like pulsatile tinnitus or something. Let me see if I can get this going. Give me 1 second, guys. Okay, here you go. Let me see. All right. See the screen, right? Another anonymized person. So I can't really like, so here's the MRA. Right there. So the fistula is on the right. And even here, you can kind of start to see that there's a channel right there. You see that? Now the channel is underneath the sinus again. But you can see that on the MR. That goes to Eitan's point. I'm sure people in like this Zoom room appreciate this, but there's a lot of people out there that keep asking for CTAs, you know, to evaluate dural fistulas. Like it really just, a lot of it is just boils down to the fact that you have one point in time to just get your contrast run straight and image it right. And if you mistime it, like the CTA is not the right way to look at these, unless we want to do dynamic CTAs. Now, a lot of us, our institution is not invested into it because of the radiation concerns, but a dynamic CTA is a totally different story. For one pass CTA, compared to MRA, I really don't see the point. Now here is basically a very similar situation. If you look at so here's a posterior fossa injection, some decent anatomical points here, right? You guys appreciate this. So here's a lateral view. Here's the vert. You start to see some, so here's a connection, right? A muscular connection from the vertebral artery to the occipital system. I'm sure we'll cover that as the year goes on, right? Now let's see if I can advance through that. Okay, we'll come back to this picture. Let me just jump forward and then we'll come back to this, right? So here's the right ICA injection. And there's a little bit of that lateral tentorial again, coming into that, like typical kind of supply. Venous phase, widely patent sinus, right there, right? So here's lateral tentorial. Sinus is patent. Typical story, so we want to understand what's draining into the sinus, this and that. Here's the external. Now this is like we're showing like there's a spectrum. We're just showing some simpler cases. Like this is a very, very simple case. You see this channel, like this is like the most obvious case that I've come across. It's like super obvious. The first time, this was first described by Mironov, Dr. Anton Mironov, actually in a sagittal sinus case many, many years ago. He published that. And there's kind of a following. There are several groups around the world that kind of looks for these channels. But I think it's under-recognized. And the more we recognize these, particularly in these low, like sort of like, you know, these type like kind of Borden Conyard type 1 fistulas, the more we can, you know, the more we can basically accomplish protecting the sinus and closing the fistula at the same time. So anyway, this is So like there's many ways to look at that, evaluate it angiographically. Like if you want to like get into imaging of it, here's a common injection, like I showed before, right? Arterial phase, you see that channel. Now in the venous phase, what you're gonna do is you're gonna make the arterial phase your mask image. And now you see again, like usually these channels are here, they're below. And so that's like, you know, whatever we have a Dyna CT, that's another, like here's a lateral sagittal view of that. You see the channel here. More of the same. Now, once you understand that, like the treatment, you know, the understanding of it usually informs you what to do with the treatment. So here again, like we come in, whatever, we find this channel and we just close it. So we put a couple of coils up there, kind of to just like stop the backflow of the onyx, and then we onyx the channel like that. I don't have anonymized the case that Eitan referred to was the coil, but you can close these with coils. Like normally we don't treat, you know, that's not how you would treat a dural fistula from, you know, certainly not from the arterial side. And from the venous side, usually you just coil it to sacrifice the sinus, but here you're sacrificing this channel. And so coils work, you know, you could do that too, whatever you want. It doesn't matter, it matters less what you use than like where you put it, basically. And so in the end, you got this, right? Okay.
Just one more thing that I have experienced, that it was a superior sagittal sinus, but the venous drainage includes through the epiploic vein. So we actually directly punctured that the epiploic vein and reach it to that the parasagittal sinus channel, injected the onyx and it cured. So I think that as Max previously said, the detailed and comprehensive analysis and understanding of the angiographic anatomy is perhaps one of the most important thing. And then as Max said, you can put the coil, you can put the onyx or glue, whatever you want, right?
No, it's just, yeah, like it's just tools. But and I would say that like these are nice examples, of course, of like an idea, like a way of looking at these. But of course, there's a spectrum. Like there are so many that, you know, you look for these channels, and sometimes there's more than one. We have like more complex cases. Also, where it works, sometimes it doesn't work. So, you know, but I think it pays to look, and we have ways to look. Like look at these beautiful pictures Kitty Pong is showing. Like there's a way to, you know, there's a way to develop protocols to get like these gorgeous venous images. We have Dyna CTs, like we have all kinds of, or Basal CT, whatever it is. We have all of these ways like to have insight into anatomy. That the purpose of like this whole meeting is to showcase that. And the more we know, the better we get. Let's see. Anybody, any questions we missed? Eitan? Anyone else? Anyone has any cases? We have a couple of minutes, so I know it's like getting to 10 o'clock. Let me stop sharing the screen. So we got, I don't know, anything else? Anyone? All right, great. So listen, so before you log off, thanks again, everybody, for coming into the Zoom room. So we're gonna, basically what the plan is we're gonna keep doing this so we're gonna alternate. Next week is gonna be like a virtual embo club. You got any cases? You wanna show something, like just email, you go to that BANANAZ page, you can email me, newranger@newranger.org. And just say you have a case, we'll put you on the list. We have a couple of people lined up to present. So that's next week. And then the week after that, we're gonna do this anatomy, kind of like a little bit more structured thing with anatomy and cases. So we're gonna be up to, I think we're up to cavernous sinus for May 5th. We are going to have this available as a recording. So the anatomy ones, like the ones, these presentations and cases will be available as on YouTube with a link from the BANANAZ page or through the YouTube thing. easily to find. Neuroangio, whatever, it's youtube.com/neuroangio. So those are available. The virtual Embo Club ones, we will not make available for now. We've had some discussion on that, and some of those cases, you know, they're all anonymous, but some of them are more anonymous than others, I guess you could say, because they're very unique. And so given that, and given like the different institutional tolerances or lack thereof towards, you know, towards sharing, we kind of want to keep that just available in live format. So if you can join, great. We're very sensitive that the time doesn't work for everybody. Of course, it's like super early for the West Coast of the States. We'll see how that goes. For now, we just have like this one weekly thing, but something to keep in mind. And then going, yeah, go ahead, Eitan.
No, I wanted to, like, we have a lot of young interventionalists online, and I mean, I wanted really to invite everybody. Like, there's no like, you know, there's no stupid question or stupid case to show. Like, really, like, I'm sure a lot of people has some cases where there's question, right? What really am I looking to, right? And this is an amazing platform for having these discussions because there's a lot of people from different countries on, and you know, like, so it's just like the perfect way to show and share questions or like weird things that we see every day. So really, like, I really invite everybody like to take advantage of this. It can be an anonymized thing, you know. You just send to neuroangio@neuroangio.org an email like with a PowerPoint. Can you show this case, and ask everybody's opinion? I think please take advantage of this. That's my comment.
All right, thank you. Anyone else? Any feedback? Anything you want us to know? Please contact us, email or you know, usually probably email is best. We might get a email list going. I'm not sure. You know, initially we don't want to get a list too much because it seems like a little bit exclusive, but nobody's going to be excluded. You just email us, we'll put you on the list. There might be a purpose to the list in terms of just communicating some things, upcoming things and so forth, and some other communication. So maybe we'll see. If there's going to be a list, basically what we'll do is we'll just let you know to email neuroangio@neuroangio.org, or we'll put it up on the BANANAZ page to email us for the list. But so far we don't have one. Just check the BANANAZ page for anything that's upcoming. And so for next week, it's the Embo Club. Any other announcements? Anything else? Anyone? All right. Okay. Again, thank you all for joining, and we will see you. We'll see you soon next week, next Tuesday.
Thank you.
Thank you.
Thank you.
What are the tips you have for us on choice of catheters, how to use maybe even some techniques that we're used to do from femoral or those access? Can you translate directly to radio first, or do you see this as a totally different mindset?
Right. I mean, I think for me, when I started, we started with diagnostics. There's other ways of doing that. Some people say maybe it's easier with interventions because it's just going one vessel. Other people think it's easier to do diagnostics. That's how we started. At that point, I was unconvinced, right? I knew it was safer to do the radial access. I knew that, but I wasn't sure that it could be done, or that maybe it wasn't high risk or some problem if I wasn't able to do a full 6-vessel angiogram consistently through the radial program.
Can everybody hear? It was a little bit hard to hear. And there was a question about radial, right? Catheters, like what to use for radial, maybe? Okay, sorry. Anyone? Any comments? All right. Listen, thank you, everybody. Again, thanks for joining. We'll see you next week.